everyone, I'm Breanna Waldrup, a speech-language pathologist specializing in childhood apraxia of speech, or CAS, and a program director of child apraxia treatment here at the Once Upon a Time Foundation. I'm happy to be here presenting this webinar about how therapy changes over time. This webinar is part of a series that's being produced in collaboration between the SATB2 Gene Foundation and the Once Upon a Time Foundation. The SATB2 Gene Foundation did a recent survey of their families and found that communication was identified as a major need. Since many children with SATB2 related syndromes are thought to have childhood apraxia of speech, we thought we would talk about how speech therapy can change over time. The biggest thing that I want you to keep in mind for this webinar is that we really want to look at the whole child, at all of their communication skills, and identify their greatest needs at the time, and then make that the focus of therapy. So many children have both a language disorder and a speech disorder. So language refers to the words we use and how we use them. It includes both receptive, or what we understand, and what we use for expression, which of course includes speech, but also includes other forms of communication. And then we also have speech, which is specifically how we produce sounds when we talk. So a child might have a language disorder that might be a receptive and expressive language disorder, meaning they're not quite understanding or using the words we expect, or might be expressive language disorder, and they may also have a speech sound disorder, such as childhood apraxia of speech. So we want to really look at the child at that time. What are their biggest needs? Do they have more language needs? Do they have more speech needs? And make that the focus of our treatment. So we'll talk through a few examples. These are only examples and guidelines. Of course, each child is unique and different, and their path will probably differ. When many children start speech therapy, they're in what we consider a pre-verbal stage. So they might not yet be talking, but they're usually trying to communicate, maybe using gestures, nonverbal communication, perhaps other behaviors. And behaviors as a form of communication was the topic of one of our previous webinars. Often, for children at this stage, their understanding is significantly greater than what they're able to express. So at this point, really their biggest need is for a consistent, reliable communication system, a consistent way for them to communicate and to build that expressive language. So we usually, of course, we want our end goal to be speech, to be that system, but we also need something in the more immediate future. And so at that time, we often look at AAC, or augmentative and alternative communication. This doesn't necessarily have to be complicated. It could be something advanced, like a speech-generating device, but it can also be naturalistic gestures, sign language, pictures, or a combination. So we definitely want that to be a big focus of therapy, is to find an AAC system that works for that child and family, and to use that system. We also, though, of course, we're going to want to work on speech, so we really want to be focusing on the prerequisites. So if we're suspecting childhood apraxia of speech, we know the most effective treatment is based on what we call the principles of motor learning. Now, we won't go into what those principles are exactly right now, but we do know that we want to be building prerequisite skills so that the child will be able to engage in that type of therapy. So the clinician will be working on building what we call therapy expectations, just the child understanding that the SLP, or speech-language pathologist, is going to be asking them to participate and do certain things in therapy. Definitely building that trust and rapport with the clinician. We want the child to start learning to focus on the clinician's face, especially the mouth, because we know that's going to be important for cueing when they start working on speech. And we want the child to start understanding that we're talking about movement, and that we're going to be really focused on movement. So when we're treating childhood apraxia of speech, we focus on movement. With children in this first stage, we might not even be worried about moving our mouths yet, but we are wanting them to start thinking about, when they're working with the SLP, that they're thinking about movement, moving their body in different ways, how they can change those movements, moving fast, moving slow, being tight or loose, moving big, moving small. If the child's not able to already turn on their voice, We definitely want to be working on that, so getting them to be able to turn on their voice, even if it's not any specific sounds, just what we call phonation, so just being just being able to produce the voice. And we definitely also want to be increasing their oral awareness. So the parts of our mouth that we use to produce speech, we really want them to be aware of those. So being aware of their tongue, aware of their lips, aware of their teeth, being aware that they of those body parts and how to move them. Again, even if we're not yet working on moving them specific ways for speech, we just definitely want to be working on that prerequisite that they know where their lips are and how to move them. So we're working on AAC, we're getting that child a good communication system, we're working on all these prerequisites, and hopefully we're starting to hear them use their voice more. Maybe they start to use a few words. And at this point, we might kind of move into another stage of therapy where our focus is going to shift a bit. So the child might be using a few words. Hopefully they're using their AAC system. Their receptive language, what they're understanding, is probably still a good bit greater than what they're able to express. And so at this point, we really feel like their motor planning for speech is their biggest need. So again, they're communicating using AAC, they're understanding language. So at this point, it might be that that biggest need is really that motor planning for speech. So of course, we'll continue the AAC, continue to monitor their language, facilitate that language growth. AAC can be really helpful for that. But we're going to then really want to begin therapy based on the principles of motor learning to really address those motor planning deficits and really focus on that speech. So we want to look at our treatment programs that are based on the principles of motor learning. Dynamic, temporal, and tactile cueing, or DTTC, is one that has a good evidence base. And at this point, the SLP will select a few target words that are motivating to the child, important, functional, useful words for the child that also are likely to be able to be successful, that the child will be able to produce, even though that might be with a great deal of help or cueing from the SLP. So therapy sessions at this point will be a lot of repetitions of those target words. And again, the SLP is going to be thinking about this principles of motor learning, which has to do with in what order they practice those words, the organization, how many times they practice those words, the feedback that they're giving the child. They're going to be using multisensory cueing, which could be things like saying the words at the same time as the child, using a slower rate, perhaps using tactile or touch cues, using visual cues, proprioceptive cues, whatever cueing is needed to help that child to be successful, and then to do that with a lot of repetition. So again, therapy is going to really be focused on speech and improving that movement accuracy for speech at this stage. So hopefully the child will progress and learn words, learn how to say words, and learn how to produce accurate movements for more and more words so that their expressive speech vocabulary will be growing. And then they might be progressing to the stage where they're starting to combine words and using phrases and sentences. So then we kind of move into the next kind of stage of therapy where the child might be using phrases and sentences, but they might not always be understood. Their speech might not always be clear. So they're not completely accurate with those movements. So there are lots of speech errors, and there very likely are also prosody errors. So those might be things like using even and equal stress, maybe a slow rate, maybe using some segmentation or pauses in their speech. At this point, they may not be using their AAC as their primary form of communication any longer, but they may still be using it as a supplement, like to clarify when their speech is not understood, or perhaps to demonstrate some more advanced skills, like maybe at school, that they're not able to demonstrate with their speech. So the motor planning for speech has improved, but it's still definitely a need. And then we're also wanting to really watch that language and make sure that their language is also continuing to develop and to be where we want it to be. Sometimes we see at this stage that some more language needs become evident. such as when the child's combining words into sentences, that we might notice some what you might call grammatical errors or word order errors, or perhaps some vocabulary deficits, where the child might be using some general words a lot, like thing and stuff, rather than specific vocabulary words. So at this point, again, motor planning for speech is still a need, but we also see this, this language need. So therapy at this point really needs to address both, and so it becomes maybe a little bit more eclectic or a combination. And there are lots of different ways that we can address these needs. For example, one example might be that we provide an intensive period of focus on speech using a program that's based on the principles of motor learning, like REST, or rapid syllable transition treatment. When providing REST treatment, you often do an intensive period of like 3 weeks, followed by a break. So you might have a period of REST treatment where you're really focusing on motor planning for speech, followed then by a break. And during that break, you might really focus on those language skills. So that's one way. You might be kind of alternating between really focusing on speech and really focusing on language. Another way to do that is to address both in one session. So not using REST, but still using therapy based on the principles of motor learning. Part of the session might be really focused on that motor planning for speech. And then the other part, with lots of drill and repetition and multisensory cueing. And then the other part of the session might be really focused on those language skills. Again, teaching some of those grammatical things, working on vocabulary, things of that nature. For some children that see more than one therapist, they might also kind of work on language skills with one therapist. Perhaps they're seeing a therapist at school who's really focused on language skills and tying that to curriculum. And then they might be seeing a private therapist who's really focusing on speech skills. So those are just some examples of how the team might address all of the needs of the child. So hopefully the child continues to progress, their motor planning skills for speech continue to improve, their language skills continue to improve. And what we sometimes see then is that the child's really able to accurately motor plan what they want to say. So the motor planning becomes a really small need, but we still see a lot of language needs. So we're still struggling with some of that vocabulary, or again, word order or grammatical constructions, things of that nature. So at that point, the child might move into a stage where they're really focused on language, and their therapy is really focused on language. Maybe just small parts are focused on speech. Again, those are just examples of one way that a child might grow and change, and how their therapy might change over time. And I really just want you to keep in mind that we really just want to look at the child's overall communication needs and abilities at that time, and really make therapy focus on what the greatest needs are. And also just keep in mind that those needs are going to change over time. So the treatment approach that works at one stage may not work any longer, or may not be the best choice after the child makes progress. So I hope that that was a helpful overview of how therapy can change over time for children with speech and language disorders, especially childhood apraxia of speech. And if there's more information that we can provide, please let us know.